Good morning, good afternoon, good evening, everyone. Very nice to see you today in our second meeting of the GN Fellowship Program that is hosted by the World Kidney Academy. We have more than 100 participants. Today is our induction meeting. 3 weeks ago, we have our orientation meeting. So today we'll give you more information about our fellowship program. As you know, that the GN Fellowship is a unique international universal flagship program. It's 1 year online program, wholly online, that includes 3 modules. Each module is 16 weeks. That includes lectures, webinars, journal clubs, MCQs, and clinical case scenarios. So this is the agenda for our today's meeting. It should be 1 hour meeting. And I'm going to give you a brief introduction at the beginning. Dr. Mushtaba Qadri is going to walk you through the syllabus and the timetable of the lectures and the topics. Then we are going to give you some information about the scientific materials, including many didactics. I'll show you some sample lectures. Then MCQs will be presented by Dr. Bianca Davidson. Dr. Manish is going to show you some clinical case scenarios, and Dr. Rasha Samir is going to show you some journal club. Then we'll give you a brief introduction about the platform, the LMS that we are using. The student engagement should be only through this platform. Then we'll open the floor for questions and answer. Here our respectable team and board members. Dr. Nikki Warren from she is associate professor at South Africa at the Cape Town University. Dr. Veronica Davidson also at the same program. Dr. Rasha Samir is from Mansoura University. Dr. Muhammad Salf is from Mansoura University. Manish is a professor and a transplant nephrologist at India, as well as Dr. Almira Ananda. Dr. Mushtaba Qadri is a professor of medicine at Pakistan. So we have huge diversity in our board and also in our participants. We have participants from 26 countries so far that include more than candidates. Why did we choose the GN to have 1 year wholly online clinical fellowship? Because the GN cases are usually challenging cases, and if not treated appropriately and precisely, it will have devastating consequences, and there is huge management gap in treating a patient with different kind of GN. There is some inconsistency and also some diversity in treating our patients. We are lacking expertise, especially in Africa and Asia, and especially in Middle East region and the developing countries. We are using the 16 weeks module to have more time for bi-directional education. It's a dialogue, not a monologue. So it depends on the student activities and engagement in the program, as well as the teacher and the speaker. There will be weekly evaluation and assessment, and scientific material will be released each Monday, and it will stay for the whole week. So it's mostly asynchronized education. So you'll have the freedom throughout the whole week to navigate through the MCQs, the journal club, to listen and watch the video, and to answer the question and to complete your tasks and assignments. Then by the end of each week on Sunday night, you need to submit your final assignments and tasks. Our objective from this program is to graduate you from trainee to a trainer level. um, we have the freedom. So because of different time zones throughout the whole entire universe, we are only meeting once every month in webinars. That is the only synchronized education. The rest of education and teaching is asynchronized. So the teacher and the student are not required to gather together, but everyone can do his or her assignments at his or her earliest convenience. Application deadline is coming soon, by next week. So make sure if you are not finalized your application yet, go ahead and finalize it. Acceptance notification will be released on November 6th. We are going to have our onboarding meeting to the final applicants and the participants on Wednesday, November 8th. So in 3 weeks from now. The fellowship should start on November 20, which will be Monday. This will be the first day of releasing the materials. You will have your username and the password, so you will have a chance to access the platform and to engage in the educational material and in the fellowship program. Here are our objectives. We need to graduate you to a trainer and the mentor level. We are planning to have more experts in this field. And by the end of the fellowship program, you will receive accreditation from the American Association of Continuous Medical Education, the AAMC, and you'll be able to write and publish editorial or review article with your colleagues. If you haven't finalized your application yet, please use this registration code that's for the participant with us today in the induction meeting, and this will expire in a couple of days. So please use that and take advantage. All of your activities and assignments will be monitored in the platform at a weekly basis. There will be a quantitative and qualitative assessment for each student depending on his or her engagement. This is a brief introduction, and I will let Dr. Mujtaba Qadri walk you through the program syllabus and the timetable. Please go ahead, Dr. Mujtaba, and share your screen.
Good evening. Again, evening from here in Islamabad, and certainly afternoon and morning elsewhere. But all are welcome today. And I'm just going to take you through the next few minutes through an orientation to our syllabus and curriculum. And can you just let me know, is this all coming through, Professor Amar? Can you see my screen?
Yes, sir. Looks very good.
Yeah. Okay, thanks. So all of you who have registered should be in possession of the manual for the program, the fellowship handbook, and that is something that I think one should keep very handy. But today, I'm just going to focus on the syllabus and the modular timetables. Uh, we have already mentioned in our introductory talk by Professor Amr that the program is almost entirely going to be asynchronous except for the monthly webinars, and I'm going to give you a little bit of a insight into that as well. Then in addition to that, we will also have some critical appraisal of the available evidence, MCQs, as we've talked about, and we're going to be seeing some samples of that. And you will also be looking at how the platform looks and how the case discussions will follow. In a sense, I will just take you through the objectives of each module and give you a small sample of who you'll be meeting as well in terms of the course faculty, particularly the international guest speakers. So module one, so in a sense, it's basically the objectives for that. It's got an introduction and basic principles of glomerulonephritis, there'll be 3 lectures. This will give basically an introduction into the glomerular diseases, while focusing on different methods of classifying and approaching glomerular disease. And it will also introduce you to the histopathological aspects of glomerular disease. The second series of talks is going to be on podocytopathies. There will be 3 lectures. And once you have become familiarized with glomerular injury mechanisms, the fellows will have an opportunity to look at different diseases associated with podocyte injuries, in particular minimal change disease and focal segmental glomerulosclerosis. In addition to that, you will also have an opportunity to look at some common glomerulopathies in this module, which will include membranous, diabetes, and IgA nephropathy. So as you can see, I think some of, you've already seen that this particular module will have a lot of what we see in terms of the core practice in glomerular disease. You have the diabetes, you have the minimal change, you have the FSGS, the membranous, and the IgA nephropathy. But certainly that is not the end of it, and you will see that we have all other aspects covered in this particular program. So this is how the module is structured, and week 1, you're going to be having an entire week basically dealing with the approach to glomerular disease, which will include a lecture of about 40 to 45 minutes, then about 10 MCQs and 9 MCQs, which will be embedded within 3 case scenarios, which each one of them will have 3 stations. And then you'll have 5 MCQs embedded within a journal club. So there may be 1 or 2 journal club articles posted. Some of them may be review articles, some of them, but most of them would be newer articles, and particularly with good quality studies. Then you're going to have nephrotic and nephritic syndrome in week 2. Again, the same theme will follow. Professor Armila Anand is going to be taking care of that. Then you'll have glomerular GN histopathology 1. So that will be by Professor Fatima Al-Husseini. Then when you come to week 5, 6, 7, and 8, we're going to be looking at mechanisms of glomerular injury by Professor Amar Al-Husseini. And then you're going to be having minimal change disease by Dr. Astrid Wines, FSGS again by Professor Amar Al-Husseini. Then these case presentations and webinar discussions are going to be particularly, we will be discussing exactly how they are formulated subsequently. Then, of course, we talked about membranous diabetes and IgA nephropathy. And then in the end, just to make things more exciting, you're going to be, so these will all have formative MCQs, but here in weeks 13 to 16, there'll be some final assignments and an exam, which will be monitored and timed, and it will be a summative, which will actually make a difference to our graduation, obviously. So I'm just going to take you through one of the case scenarios. I'm not going to read through it, but I'm just going to play it.
No further tests need to be ordered to go then nephritis stress. So when you look at the urine dipstick, I think all of us are familiar with the urine dipstick. And
so these are lectures. So this is a little bit of a sneak preview into the first lecture, the introductory one. And I have the privilege of doing that. And certainly I can tell you that, so you're going to be seeing a lot of things and a lot more detail subsequently. Now, when we're coming to module 2, you have your secondary glomerulopathies, so 3 lectures. Here, the fellow will learn how to properly diagnose and treat secondary GN, and we'll be looking at some related GN histopathology and focus on lupus nephritis and the small vessel vasculitides here. Then GN in special circumstances will address hereditary nephritis, GN in pregnancy, and the onconephrology aspects. I think that we are realizing are becoming more and more common, that the nephrologists are having to deal with all these checkpoint inhibitors and other biologics and antibodies in the pipeline that are developing. We also have rare glomerulopathies where we'll be looking at, in particular, amyloid and non-amyloid and different immunoglobulin and complement structures, and dealing with amyloidosis, fibrillary and immunotactoid GN, as well as MPGN and C3 glomerulopathy. So this is how it will be structured. The GN histopathology, part 2 will be done by Professor Fatima Al-Husseini again, lupus nephritis by no less than Brad Robin. And I don't want to spend time talking about him here. Small vessel vasculitides, Professor Bianca Davidson, our core faculty is going to be doing infection-related GN. Again, our core faculty, Professor Nicola Wern will be addressing that, GN in pregnancy, Professor Rasha Samir. And then you have GN in onconephrology, Naoka Murakami. Then you have amyloidosis and fibrillary and immunotoxicity GN by Professor Amar Al-Husseini, the MPGN by, again, no less than Sanjeev Sethi, and C3 glomerulopathy, again, by Professor Amar Al-Husseini. And each one of them, the series of 3 or 4 lectures will be followed by a live synchronous webinar. And how will we be structuring that? We'll talk about it subsequently. So when you're looking at module 3, here again, it's basically a chance to look at hereditary nephritis and role of genetic studies in GN, post-transplant GN, both de novo and recurrent, as well as the thrombotic microangiopathies. Then in addition to that, then there'll be traditional and novel GN treatment approaches where we'll be looking at both the non-specific management, the standard immunosuppressives, a particular talk and session, but completely on plasma exchange, and the novel and pipeline therapeutics, again, with Professor Brad Robin will be doing. So here is the timetable for that. And we also have, additionally, we have Professor Ahmad Shokir from Canada, Professor Manish Rathi, again, our core faculty from India, doing thrombotic microangiopathies. You have non-specific approach to GN management, Professor Patrick Nackman. And then besides standard immunosuppressive by a program director, you have role of plasma exchange in GN by Professor Sadiq Ahmed, and novel and pipeline therapeutics we just talked about. And then the exciting part, which is the final exam. So how will the webinar follow? So every month, following 3 lectures, lecture weeks, or 3 lectures, which will all be related to a particular theme topic, as you can see now. Then this webinar format will have a live and synchronous session at 3 p.m. GMT for about an hour. It will be on a 4-weekly basis. All members of the faculty and fellows are expected to participate in it. And the fellows, so you get to present cases that you see in your practice, in your wards, in your clinics, outpatient, inpatient, either. And then you can present it in the form of a clinical pathological conference, or any other aspect that one can do. But there'll be a assigned faculty mentor for those group of fellows who will be presenting. And one could have 1 to 2 cases typically, but sometimes you may have 3 or 4 if they are smaller cases. And usually live patient encounters, all anonymized, of course, would be presented, or virtual scenarios can be created. So, and the discussions will be fellow driven, but mentored, of course. So I think this would be a great opportunity for all of us to keep meeting and keep the excitement going. And I think this will be a great learning opportunity. So these are your international guest speakers. You can Google them, and you can go and look at their backgrounds. And I can tell you, just for all those who have kept up despite COVID and other times, these are some stalwarts from I would say not historic times, but pre-COVID times as well. And they have carried the flame and the torch as torch bearers in nephrology. So you're going to be learning a lot from these particular sessions. And I would say that these 45 minutes set the tone for the activities of the week that they will be talking about. But besides that, you've already met our core faculty, the program directors, and the academic director, and the academic and co-program directors. They've all been introduced. Besides that, you will also be meeting Dr. Shirouk here, and Dr. Mahmoud Sob, and you'll also be meeting Professor Muhammad Al-Saftawi. So these are the primarily the core faculty members, and I thought it would be important to put some pictures to their names so that we are dealing with, so you obviously know who we are dealing with. So in summary, there'll be 3 modules of 16 weeks each with 20 credit hours. So you're looking at spending an average of 20 hours a week for those 14, 15 weeks, just like you would do in a semester. about 2/3 of those activities are self-directed learning, and 1/3 time will be spent on the platform. So look at an average of an hour a day on the platform and an average of 2 hours a day doing self-directed learning for about 6 days of the week. However you want to structure that, that is up to each individual. You'll have your invited international guests, academic board member recorded theme lectures. The journal club will be very much related, like I said, and we'll have some MCQs to ensure that we actually are learning through the key guidelines or the methodology and related aspects that would inform our practices. The MCQs are predominantly formative, so they not only will be, so you'll be seeing them subsequently some examples, but they are also all higher order MCQs, so they're not your simple C1 level MCQs that people are familiar in educational terms. They are C3 higher cognitive levels, with application and being the most important thing, which includes all your synthesis and other aspects of MCQ development. So they'll be there, and you'll have rationale for both correct and incorrect responses, as well as the references from where these MCQs may have been derived. You'll also have your case scenarios, and I think we'll be seeing that subsequently as well, similar way. And then we will be having your synchronous webinars and the summative examinations. So I think I will end right here, and welcome aboard, and we are delighted to have you in this fellowship program. Thank you, Professor Amr.
Thank you so much, Professor Mustafa, for this very nice comprehensive description about the syllabus and topic and timetable. Now I'm going to show you a brief mini didactics, one of the lectures. It's just a sample of the lectures that you will have throughout the course. I will, it's like 10 minutes, but we can just show you maybe 5 minutes. Let us just listen and watch this video about the renal pathology.
This is a brief overview of glomerular diseases. So we will cover most important primary podocyte diseases that present with nephrotic syndrome, and then I will move over to most common nephritic lesions, and then at the end I will talk a little bit about a couple of different systemic diseases. So what you see here is a schematic of a glomerulus with 4 capillary loops, and I really want you to pay close attention to GBM that goes around and wraps around the whole structure. It goes from one capillary to another, separating the intercapillary space and the mesangium from the extra capillary nephrotic type picture. And the cells will look like this approximately. So you will have a diffuse effacement of foot process. The cells will not be able to keep that ultrastructure with the foot process. So the cell will just sit on top of the glomerular basal membrane. If you look at the light microscopy in such lesions, you will see actually normal structure, but when you look at the electron microscopy, you will see diffuse effacement of foot process. This is minimal change disease type lesion. So you have cell dysfunction. Now, if you imagine that you have a very severe injury to the podocytes, where you can develop extensive effacement of foot process, but also cell death. It's hard to make a really real picture of cell death, but you can imagine, that this is a very unhappy cell about to actually get detached from the glomerular basal membrane. This is really what happens in focal sclerosis, and this is how focal sclerosis is different from minimal change disease. So some cells will die off and detach from the GBM, and this is the place where one will develop initial hyperfiltration across the membrane and then consequent segmental hyalinosis. And by light microscopy, this translates into focal and segmental sclerosis. Membranous nephropathy is another important nephrotic lesion, and what you have there is a renal-limited autoimmune disease. In its primary form, about 80% of patients develop antibodies against a specific membrane-bound podocyte antigen, so-called M-type phospholipase A2 receptor. So And because of that, the basal membrane will start creating spikes to help podocyte attach better to the basal membrane. And you can see these spikes if you stain the section with silver stain, because the silver stain really stains basal membrane material in black, and it will not stain deposit. And during that time, that's actually the dystrophin reaction, which will result in drop in GFR and increase in creatinine, and this will result in decrease in urinary output. The picture that goes away rather quickly within a few days as the subendothelial dense deposits get removed, and subepithelial deposits will actually really remain there for a longer time because they're outside the circulation, similar to those subepithelial deposits in membranous. Subendothelial deposits in more of a chronic way. For example, um, you have a patient with chronic antigenemia that is either chronic infection, such as chronic viral infections, hepatitis B, hepatitis C, number of bacterial infections with abscesses or endocarditis. Picture. So you have subendothelial deposits that don't get removed easily um, um, because you have either, like also defect in the immune system, or it's just like too much on the immune system to remove these, or they're not really effectively activating the inflammatory response here. It's where you have formation of antibodies against glomerular basal membrane, anti-GBM disease. So you form these antibodies, they bind to the basal membrane. You can see that by immunofluorescence as diffuse linear staining with immunoglobulin G. Examples is anti-GBM, but there are other things that can create crescents like ANCA disease and immune complex diseases, including post-infectious that I already mentioned a little bit ago. So these are nephritic lesions. And as promised, I will go over a couple of systemic diseases, diabetes and amyloidosis. Both of them are really, GBM also becomes thicker, injury to the podocytes, and basically every cell type will suffer. Um, Amyloidosis is a disease of also systemic disease with deposition um, in the glomeruli, tubular interstitium, vasculature, but in the glomeruli it starts from the mesangium, where you have the position of this acellular amyloid material, and it goes actually through the capillary walls and down the capillary walls and completely destroys the structure of the glomerulus with formation also of amyloid nodules and so on. The material is congruent positive, gives apple green birefringence under polarized light. There are a large number of proteins that can form amyloid. Important ones are light chains in multiple myeloma and serum amyloid A in reactive amyloidosis that is associated with inflammatory conditions such as rheumatoid arthritis, inflammatory bowel disease, and so on.
It's just a sample of the videos and the lecture that you're going to see. It's mainly based on artificial intelligence and using the up-to-date, information and technology. So hopefully you will enjoy this lecture. Again, the program is not designed to be based on lecture, but more on the bidirectional interaction and engagement. So you will have every week only 20% of the contribution of the fellowship will be the lecture, but there will be also webinars, there will be clinical case scenarios, MCQs, and also there will be a clinical case scenario journal club. Now, Dr. Bianca Davidson, she is going to show us some samples of the MCQs that you will have every week. So every Monday morning, you will have lecture, MCQs, clinical case scenarios, and journal club. Go ahead, please, Dr. Ban.
Hi, everybody. It's lovely to meet you. Good morning, good afternoon, and good evening. Can everybody see my screen?
Yes, we do.
Great. So I just want to introduce myself. My name is Dr. Davidson. I'm part of the committee, and I'm very excited to be lecturing you on small vessel vasculitis. My job today was to give you a couple of examples about our MCQ part of the course, and this is actually probably my favorite part. I think it's a great way of not only establishing what you have learned from the session, but also to cover a broad range of topics in quite a short space of time. So the pros of the MCQs of our program, you will be taught a lecture within the week. You will then have 10 MCQ questions that will be based on the lectures. It will reinforce the most important topics, which is a great way of learning. It will assist learning through explanations. So we will give you explanations not only for the right answers, but giving you examples of why the wrong answers are so. It's a quick way to cover a lot of different topics, and if you get stuck, there are members of the staff that are there to help you if you're not understanding some of the explanations. So as I'd mentioned before, there's 10 MCQs for each of the modules. It is flexible. You get to do them in between work. There aren't any time limits to the MCQ questions. You can do it after hours. It's asynchronous learning and really is done at your leisure. And as we had mentioned before, it's a great way to assess what your understanding of that topic was. I'd like to just take a few minutes to run you through two of the examples of MCQs that you will come across within our lecture series. So the first question is, what is the mechanism of action of avacopan, a drug used in ANCA vasculitis? Is it A, a C5a receptor inhibitor, B, a C5 inhibitor, C, a C3b inhibitor, D, a C1 receptor inhibitor, or E, a C5b inhibitor? So a normal MCQ would just give you the answer, and I'd just like to show you what our program does. So there's quite a lengthy explanation behind it. It will tell you the right answer is C5a receptor antagonist. But the nice thing about it is that it will then take a little step back and explain the pathogenesis of ANCA vasculitis. Again, the role of the complement system, the role of activation of the neutrophils, and this way we'll just will reinforce what you have learned already. We have quite a lot of visual aids that will help you to think through the complicated pathogenesis behind questions. And once again, this is a great way of reinforcing learning. So from one MCQ question, we will not only be covering the mechanism of action of newer treatment and mentioning trials in which they were studied. We will also be looking at the basic pathogenesis of the disease, and this is quite a nice way of assimilating knowledge in quite a short space of time. So MCQs we love, once again, because they are reinforcing, they are revising, and they are very relevant to all of the topics that you will be learning. The second question that I wanted to show you is an example of a clinical question that will come up in your MCQs. I love these because it'll give you a chance to think about cases that you will be seeing every day within your practice. So a 72-year-old man who's known with GPA attains complete remission after induction with intravenous cyclophosphamide. He is currently being maintained on azathioprine for the last year and a half post-induction. He presents to the emergency unit with a 1-month history of worsening shortness of breath, a low-grade fever, a dry cough. His ANCA serology is repeated, and his proteinase 3 antibody titer is 1 in 1,280. The full blood count is normal. His urine demonstrates hematuria, and his creatinine is raised from its baseline. He has a CT chest, which is shown in the picture below, and he has started on methyl prednisolone. And the question is, what is the next most appropriate treatment? Do you continue the azathioprine? Do you repeat the cyclophosphamide induction? Do you change him to MMF? Do you change him to rituximab, or do you start methotrexate? So as I had shown you before, you will be given the answer after you have attempted the question. So cyclophosphamide and rituximab are both used in the induction of remission and to treat relapses in GPA. Although both provide similar efficacy in treatment, rituximab has fewer side effects, and then it will go on to describe the trial that it was shown to be beneficial in. As I had mentioned before, not just the correct answer will get explained, the incorrect answers will be explained as well. So azathioprine is incorrect. This patient has had a relapse, and you will need to change induction agent. Cyclophosphamide is incorrect for the explanation that I'd given you above, with the RAVE study showing that rituximab is superior to cyclophosphamide in relapsing disease. MMF is really only used in remission induction of mild disease without organ involvement, and methotrexate was inferior to cyclophosphamide in maintaining remission. So once again, it's one clinical question, but we're going to bring in treatment. We're going to bring in the trials that this treatment is based on. It's a great way to revise and reinforce, and it's probably one of my favorite teaching methods. So I'm really excited to share our MCQs with you and work through them with you and be here when you get stuck with them. So it's lovely to meet you all, and I'm excited to meet you all further.
Thank you so much, Dr. Vanka, for this illustration. Dr. Manish Rathi is going to show us some example of the clinical case scenarios as well.
Yeah, hi, good evening, good afternoon, everyone. Excited to see you all here. I'm Dr. Manish Rathi. I'm professor of nephrology at PGI Chandigarh. And so I'll be showing you about clinical case scenarios. So basically, Dr. Bianca has done a wonderful job about explaining about MCQs and how the MCQs will be given to you and what will be the explanation. So basically, clinical case scenarios are also like MCQs, but they are different from MCQs in the way that at the end of each lecture, you will have 10 MCQs, and all these 10 MCQs will be unrelated to each other. While in clinical case scenario, we will be taking you through a case which will be progressing in each question. So all the questions will be related to the same case, or maybe we will have two cases, and the questions will be related to each other. So you will progress your questions along with the case progress or case journey, and the cases will be interesting. They will be like the cases you will be dealing in your OPDs or in your inpatient practice. So here I am showing you an example of minimal change disease case scenario. So suppose you have a week where the talk is on minimal change disease. So after that talk and after MCQs you have attempted, you can go to the clinical case scenarios, and something like this will be there. So in minimal change disease, you will be given a case like this, that we are dealing with a 16-year-old female who presents to you in your OP with nephrotic syndrome with protein excretion of 10 grams a day. Serum creatinine was normal. Clinical examination was normal. Blood pressure was also normal. And she was started on oral steroids with good response, and within 9 weeks, her proteinuria decreased from 10 grams to 150 milligrams. And so prednisolone was slowly tapered. So typical case of minimal change disease. So question which you will be asked is, which of the following patient's clinical characteristics represents an overlooked indication for renal biopsy? That ideally this patient should have been subjected to renal biopsy, but this patient was straight away given treatment. So there are 5 options, and you can go through them, and you can write in the chat box that what do you think is the most appropriate answer, that which is the most appropriate indication that should not have been overlooked and decided in favor of doing a renal biopsy, like age or presence of edema, renal failure, late response to corticosteroids, or presence of 1 to 3 RBCs. So once you have decided that this is most appropriate question, then you will be given a correct answer. So correct answer in this case is A, that age is more than 12 years. And similar to MCQs, we will be giving you rationale that why this answer is correct and why other answers are incorrect. So according to KDIGO guidelines, age more than 12 years is an indication to perform a renal biopsy. And we will also give you explanation that why other things are not indication for renal biopsy. For example, if you go back, edema is a common finding. Renal failure can be related. In this case, is because of hypoalbuminemia, so you don't require a renal biopsy. Late response to corticosteroids, again an indication, not an indication for biopsy. And for RBCs, if there is presence of macroscopic hematuria, it rules out MCD, but just 1 to 3 RBC does not rule out a minimal change disease. So we will also give you a reference that you can go and read it in detail for this justification for this answer. Then we will go to the second part, and again this is the progress of the case only, and related to the same case, that which of the following statement is true regarding management plan of this patient. So one of these 5 statements is true, and other four are wrong. So you have to go through these statements and decide which one is the most appropriate or correct statement in this case. Like kidney biopsy holds prognostic value, more prognostic value as compared to steroid response and number of relapses. If patient is biopsied, most probable diagnosis will be FSGS. Being steroid sensitive, this patient's prognosis is mainly determined by medication related morbidity. The aim of treatment is to maintain remission, even if we require a high cumulative doses of steroid, and use of ACE inhibitor is essential before starting glucocorticoids. So again, you can write your answers in the chat box. And again, when you decided which is the appropriate answer, then you can go to the correct answer. And the correct answer in this case is that being steroid sensitive, this patient's prognosis is mainly determined by medication related morbidity. And again, this will be followed by a rationale, which will give what is the reason why this answer is correct and what is the reason why other answers are incorrect. And so there will be a detailed justification for this, and this will again be followed by a reference. Then once you have attempted this question, then you will again, as I have said earlier, you will progress with the case, and now the case has progressed and come back to you 4 years later. And 4 years later, this patient has come with peripheral edema and now proteinuria. This patient was in complete remission. Now it has increased to 6.5 grams a day. Renal functions were still normal. Blood pressure was still normal. So a renal biopsy was done because now this patient is 20 years of age. And you will also be given, depending on the case and depending on the questions, you will be given histopathology, or you will be given some diagrams also, which you have to read. There will be description of the diagrams also. Like in this case, this is a minimal change disease with normal appearing glomerulus. And then you will be given an electron microscopy picture, that this is the electron microscopy picture. So then it will be followed with the question that which of the following electron microscopy finding is consistent with diagnosis of minimal change disease. So the options are in front of you: diffuse effacement, diffuse subendothelial and mesangial electron dense deposit, and so on. And I think this question is a relatively simple question, that diffuse effacement is a hallmark of podocyte injury. But what is important is not only you will be given correct answer and explanation, you will be also be given explanation for each of the wrong statements. So you will also get to know the idea. Like suppose in this case there is diffuse effacement, we all know is characteristic of minimal change disease. But where can we find diffuse subendothelial and mesangial electron dense deposit? Where we will find subepithelial electron dense deposit? Or where we will find this kind of fluffy material? All these answers will be provided in the explanation. Like in this example, you will be provided with all the explanations. So not only you will come to know which is the typical electron microscopy finding of minimal change disease, you will also come to know what are the other findings in other diseases. Uh, and then again related to this question, this patient only, that which of the following urinary finding is suggestive of relapse in this case of a nephrotic syndrome? So please go through these options and write down your correct answer. So there will be multiple options for each question. There will be 5 options and you have to choose most appropriate answer. So in this case, what do you think is the correct answer, which is suggestive of a relapse of nephrotic syndrome in a case of minimal change disease? So after attempting your question, you will be given a correct answer, which is answer option E, which is urinary CD8T. So again, you will be given that urinary albumin protein ratio is not a correct answer. It is albumin creatinine ratio. Then NGAL, and why NGAL is a marker for acute kidney injury. What is the explanation for urinary CTLA4? What is explanation for MCP1? And finally, what is explanation for this correct answer? Everything will be provided to you along with detailed references, which you can go through these references and read it in detail if you require further information. And according to aforementioned clinical course, this patient nephrotic syndrome can be classified as which of the following? And again, I think this is a relatively simple. This patient is presented with relapse 4 years down the line. So this becomes a steroid responsive, infrequently relapsing. But again, the beauty lies in the explanation, that you will be given all the detailed explanation that what are the different definitions and what are the different cutoffs depending on which guidelines you are dealing with. And I think this is the last question from my side. Again, for the same question, same patient, sorry, which of the following statements is false regarding glucocorticoid use in this patient? So one out of these statement is false. Maximum duration is 16 weeks. Tapering of glucocorticoid should be initiated immediately after achievement of complete remission. Route and frequency can be individualized to the patient need. In case of glucocorticoid contraindication, initial therapy can be with cyclophosphamide, CNF, MMF, or rituximab, and long-term kidney survival is excellent. So again, you have to read question carefully, that you have to identify which is false out of these 5 statements. Other 4 statements are correct. And then similarly, you will be given this thing, that what is the correct answer and what is the explanation along with the reference. So thank you very much for this listening from my side. I think we can end here, and happy to see you all in our clinical fellowship program. Thank you.
Thank you so much for this comprehensive description of the clinical case scenarios, Professor Manish Rathi. Now we are going to move to the last component of the scientific material. Dr. Racha Samir is going to share with you and walk you through the journal club. Every week you will have a state-of-art manuscript, either 1 or 2, so that you can have a chance to read throughout the whole week. Then you will be questioned about this article. Go ahead, please, Dr. Raj.
Hello, everybody. This is Rasha Samir, Assistant Professor of Nephrology, Nasra University. It's my pleasure to be part of the World Kidney Academy GN Fellowship Program. Today, I'm presenting a very brief presentation, giving example of what actually will interact with our journal clubs. I choose the management of IgA nephropathy as one of the frequently touched topics in clinical practice. So when you access the platform, you will have 3 types of the most updated, informative, and comprehensive articles to read, deeply understand, which may include review articles, landmark trials, and international guidelines. So as for my topic, as an example, I choose the KDIGO guidelines for the topic, the management of IgA nephropathy, where when you diagnose a patient with IgA dominant GN and make a diagnosis of idiopathic IgA nephropathy, scored the kidney biopsy using the currently used MIST-C score, and then risk stratified the patient. The initial management would be optimized supportive treatment with blood pressure management with maximum tolerated dose of ACE inhibitors, ARPs, beside lifestyle modification. And that all patients should be managed according to KDIGO, particularly patients with proteinuria more than 0.5 gram per 24 hour. For those who not have a good response or still have a high risk after 6 months, after 3 to 6 months of maximal supportive therapy, they will be considered for a 6 months course of glucocorticoid therapy. High risk of IgA nephropathy is currently defined as proteinuria more than 0.75 to 1 gram despite plus or minus 90 days of optimized supportive treatment. So for patients who do not respond to 3 months of optimized supportive care and don't have high risk of toxicity with glucocorticoid, so corticosteroid risk-benefit profile acceptable would be the best option according to the KDIGO. And remember that it's not applicable to IgA vasculitis and other forms of IgA nephropathy. And because the evidence is continuously growing, you will have on the platform new articles, maybe discussing the new changes and updates in management of IgA nephropathy as this one. And all the trials discussing the landmark trials or the clinical trials discussing the treatment of IgA nephropathy starting from early 1999 till the current time, comparing the immune suppression versus the maximal supportive treatment or maximal treatment of blood pressure with RAS inhibitors, till the stop IgA nephropathy trial, which may be a key landmark trial. Now we're introducing a new era of complement inhibitors. So the articles present a new topic or a new era of treatment for IgA nephropathy, which is complement inhibitor. Here, all for the competitors, and now have good discussion in the article about the pathogenesis and the role of complement in the pathogenesis of IgA nephropathy and the role of new complement inhibitors, which may represent the future treatment for IgA nephropathy. For this, I'm just presenting a couple of questions. When you finish reading the very interesting article about the updated management of IgA nephropathy and the role of complement inhibitors in the management, then you will have formative MCQ questions to test your knowledge, test your understanding of the topic. So just presenting two examples of this, which one of the following complement components has been histologically detected in up to 100% of patients with IgA nephropathy and correlate to high risk of IgA nephropathy progression. So you can be back to this part of the article discussing the pathogenesis and role of complement in the pathogenesis of IgA nephropathy. You will find that C3 is the most abundantly detected component in the mesangial deposits in patients with IgA nephropathy, reaching up to 100% of patients. And when we talk about the new era of complement inhibitors or treatment of IgA, we think that we need a new guidance of treatment. So if you're going to treat a patient with a complement inhibitor, what do you think may provide the best guidance for treatment? Do you think predominant IgA deposits on a kidney biopsy, the percentage of mental sclerosis, tubular atrophy, and interstitial fibrosis in more than 50% of the biopsy tissues, the type and amount of the complement deposition, or immune histological detection of the complement in the mesangium? Which one do you think will be providing the best guidance with the complement inhibitor will be the type and amount of composition, which necessitates better sterilization and providing better diagnostic tools for diagnosis and follow-up of the patient's response to treatment with complement inhibitors. Just a very brief talk and very brief examples, and thank you. We're hoping to be continued in the course very soon. Thank you.
Thank you so much, Dr. Rasha, for this nice illustration and description of the structure of the journal club. For the sake of the time, I'm going to show you briefly the platform that you're going to use. As I mentioned previously, we will have onboarding meeting on November 8th. So if you finalize your application, you will get a username and password to this platform. You see the platform here is World Kidney Academy. So usually start with the World Kidney Academy. And here's a course, which is the GN. Then after you log in, you will have your name or description somewhere here. And you can see this is the first week. From here, the left upper corner, you can see the weeks that you have, week 1, week 2. Under week 1, you will see the component of this week, which is start on November 20. We'll have the lecture, approach to glomerular disease. You will have the MCQs for week 1. You'll have a journal club, and actually we have 2 journals, we have 2 articles for this week. Then you will have clinical case scenarios. We have 3 clinical case scenarios. So this is Dr. Mushtaba Qadri lecture. And here I'll show you the MCQs. You can navigate through that. So the MCQs usually are 10 MCQ questions. And here an example of the MCQs. And here are the right answer. I don't want to show you, don't want to burn out whatever you're going to learn. So if you have the wrong answer, it will show up in red color. Then after finishing the 10 questions, you will get the answers right away with the rationale for the right and the description why the wrong answer is wrong. So everything will be automated. All the exams, all the tasks and assignments will be shown in the platform. And as I mentioned, you will get a username and password for this platform before starting the course on November 20. And we will have the onboarding meeting on November 8th, and by that time, hopefully you will have your password and username, and you'll have access to samples of the scientific materials. Here is first week journal club. So this is the Kiduki US commentary on the 2021 KDIGO clinical practice guideline for glomerular diseases. So you'll have the chance to read this article throughout the whole week. Then you go and try to answer the question. Again, the questions here are not to evaluate or to assess. It's not a pass and fail test. It's just a way to teach you, better and to explain why the right answer is right, why the wrong answer is wrong. So it's an educational material. And here are example of the journal club questions. And here is the answers and explanation. Usually it's detailed explanation. So it's an educational chance you can take to learn more and more throughout the course. I think I will stop by here because of the sake of the time, and will open the floor for discussion. Dr. Shuru Nagar, she is managing the chat box. So please let us know if you have any questions, concerns, or any suggestions. So please go ahead, Dr. Shuru, if you have any question in the chat box.
Yes, Dr. Am, we have 2 questions. The first question is the best textbook that the student can follow as they are enrolled in our course?
We don't dictate. We know that you are not undergrad student. We don't suggest or dictate any or recommend any of textbook. You can do whatever you want. The most important thing for us is even if you can focus on the scientific materials you will get over the 16 weeks for each module, this would be enough to cover the whole materials. But of course, if you want to do extra reading in a comprehensive nephrology book or Brenner and Director book or any other materials, you are free to do that. But we will give you a lot of scientific material. It would be great if you focus on those, because we are actually going also to give you supplementary materials, not only the scientific materials that are going to be tested, but we'll give you more and more articles and the studies, big RCTs and state-of-art manuscript to read if you have extra time. So this will cover, the whole educational, interest throughout the whole year.
Another question, what is the pass scores of the exams?
So as we mentioned, these tasks and assignments are not really exams. They are educational material that you need to be engaged throughout the modules. So your contribution and the engagement are the activities that you're going to be assessed based on. We are not going to assess your knowledge, but by the end of each module, there will be an exam, usually 10 MCQs and also some clinical case scenarios. Then you need to get at least 60% pass score to do these final assignments and tasks. But again, this will be only by the end of each module.
Another question, what time online courses will be available? At what time?
The platform is open 24/7. You will have username and password. You go whatever time. Dr. Mustafa gave you a brief description of the hours you need to study, but you can do all of these hours in 1 day or 2 days over the weekend or over the weekdays. So you will have the whole week to watch the lecture and to read the article and to answer the MCQs and to finalize your task. So this is at your earliest convenience. So the scientific material will be released on weekly basis on Monday morning, and you are supposed to do your assignments by Sunday night. So by Sunday night, make sure that you submit all your tasks and assignments.
Another question about the schedule of monthly meeting.
Every 4 weeks, we should have a webinar, and this webinar, we encourage you to present cases. It will be clinical case-based discussion webinars. So students and participants are supposed to present challenging cases and to discuss it with the board and with the teachers. So again, this will be only one time every month.
Another question about the cost of the course and the method of payment.
I think you already shared the registration link with the participant. The course is each module is $292, but if you do the 15% discount using the GN15, it will go down to around I don't know 250 or so. And if you're doing the whole package, it will give you 10% discount. So make sure to take the 10% discount for the whole package, the 3 module, if you want to pay for the 3 modules, and to get the 15% discount using the GM15.
Yes, another question, what is minimal qualification to join the course, and is it useful for a pediatric nephrologist or not?
Yeah, we have some pediatric nephrologists are with us already. They finalized their application. Of course, there is a lot of similarities and some differences, in pediatric and adult nephrology, but the principal mechanism and the principal pathogenesis is almost very similar. But when it comes to treatment, there is some differences, and we are going to give you some idea. It's not designed for, to be focused 100% on pediatric nephrology, but also will give you some idea about the differences in pediatric nephrology. But it's mainly an adult nephrology, but we are open to pediatric nephrology, and we can also focus on the webinars on challenging cases in children as well as in adults.
Yes, another question, if there is any obstacle to submit the assignment at the end of the week, what will be the situation?
You email or contact the program director, and we can give you exemptions. There is, limits for the exemptions. but on an individual or particular cases, all of us has some social emergencies or some circumstances that we cannot do our, assignments or tasks. That should be fine if it is limited to, a specific number of weeks, and you should get approval, individual approval from the program director and the module lead.
Can I register the second module after finishing the first one?
Absolutely. You can register for the first one only, or for the second or the third. They are independent. However, we highly encourage you to start from the first module to second to third.
Dr. Hani says he paid for the first module, but he didn't receive a confirmation yet.
We'll contact him. What's his name? Hani what?
Hani Topia.
We'll contact him. We'll let the program administrator to contact him and send him, some proof of his payment and application.
Okay, what are the other